Good morning, everyone. I would like to present before you the outcomes of combined ruthenium plaque brachytherapy with transpupillary thermotherapy in thick choroidal melanoma. So uveal melanoma is a common primary malignancy in adults. It is life and sight-threatening if not treated at the time. The treatment modality is mainly determined by the size and location of the tumor. Since the advent of brachytherapy, there has been a change in the line of treatment of melanomas depending upon the size. So brachytherapy mainly delivers curative dose to the tumor while it protects the surrounding normal ocular structures. Whereas in transpupillary thermotherapy, which can penetrate up to 4 mm depth, it causes necrosis, thus destroying the tumor. The rationale of our study was that we treat the tumor from behind by keeping a episcleral plaque, ruthenium 106, along with treating the tumor anteriorly by transpupillary thermotherapy. So the ruthenium produces beta radiations when compared to iodine 125 plaques, which normally produces gamma radiation. Since beta radiations are not that much penetrating like gamma radiation, the untoward complications or untoward radiation to the surrounding structures were minimized. But the major concern was that because it has a steep dose gradient, steep dose fall rate, the apex may not receive adequate treatment if the tumor is more than 7 mm. So we assessed primarily the outcome of the combined treatment and secondarily the other parameters like ocular surface, hysteresis of the cornea, visual acuity, IOP, etc. The study period was 1.5 years. It was a prospective interventional study. The tumor thickness we considered were apical thickness ranging from 5 mm to 8 mm and largest basal diameter not exceeding 16 mm. A convenient sample size of 10 patients were recruited. So initial pre and post-operative assessment were given. The patients were confirmed with ultrasound assessment of the tumor and clinical examination. After getting proper consent, the radiation dose was calculated by the radiation oncologist. TTT followed by plaque brachytherapy was given in the same sitting. After removal of the plaque, 3 cycles of TTT were given in the consecutive month. At every 6 months and 12 months, metastatic assessment was given. So there was a statistically significant decrease in the apical thickness at 3 months, 6 months, and 12 months. The percentage reduction at 12 months was 72.31% among tumors with apical thickness of 5 mm to 6 mm, whereas in tumors with apical thickness of 7.1 to 8 mm, the decrease in the apical thickness was 17.81%. So figure 1 shows a pre-op ultrasound showing the tumor, whereas post-treatment, the figure 2 shows no visible tumor. Figure 3 shows a pseudocular image where we can see the tumor marked by the black arrow, whereas in figure 4, there is a flat scar with associated radiation retinopathy. The mean scleral dose was 518 gray. The mean tumor apical dose was 78.5 gray. At 1 year, the mean apical thickness reduced to 3.4 mm. Tumor control and globe salvage rates were 100% at 1 year. At 1 year, 1 patient developed distal metastasis, which was diagnosed in PET CT scan. It was in liver and vertebra. The patient was referred to oncology department later. And 3 patients developed radiation retinopathy. So we believe in tumors with 5 mm to 8 mm apical thickness and LBD less than 16 mm, the combined ruthenium plaque brachytherapy plus TTT can be used effectively, and higher response were seen in tumors with apical thickness of 5 mm to 6 mm. Thank you. Yes.
Setting of the TTT that you used for your patients?
Yes, ma'am. We used a 810 diode laser, and the spot size was 3.4 to 4 mm, depending upon the location. And the setting was about 400 milliwatt, and the exposure time was around 1 minute. In case if the tumor was not responding, we increase the power by 50 milliwatt of increment till we get a grayish white discoloration.
And what was the maximum time you were using on maximum number of spots per session of TTT?
It was like maximum number of spots.
Yeah.
Ma'am, it was around like 10 to 12 spots per second.
Okay, and what was like TTT? How many sessions were required for this 10 patients that you showed?
Ma'am, initially we gave before the placement of plaque. Then after removal, in first, second and third month, we gave a TTT. So in 2 patients, after second TTT, in tumors which were around 5 mm, they were completely a flat scar. In the tumors more than 6 mm, we had to give a third TTT also. But till now, after the study period, we are following up the patient. After the third dose of TTT, none of the tumors have progressed in size. Everything is stable. So we are keeping the patients under follow-up. In case the patient, we do not feel like it has not reduced like we have planned, then we give an additional TTT depending upon the progress of the tumor. But that was out of the study period, so I have not included it in this.
Okay, thank you.